Before we get started, please remember this podcast is for general educational purposes only. We're not providing medical advice, diagnosis, or treatment. Always consult your own healthcare provider about your care. Welcome to Fertility Nurses Unfiltered. 2 nurses, 1 mic, no bullshit. I'm Ashlee LaRue, fertility nurse and founder of Fertilities.
And I'm Laura Wepler, fertility nurse and founder of Navigating Fertility with Laura.
You got questions, the internet has a lot of opinions, but what you really need is 2 fertility nurses who aren't afraid to tell the truth.
No scripts, no sugarcoating, just honest, evidence-based nurse-to-nurse conversation. So let's get into it.
Hey everyone, welcome to this week's episode of Fertility Nurses Unfiltered. We're super excited to be with you. And I'm really excited about this topic, and I think it comes at a really good time since we talked all about IVF and what to expect and what people don't really share or talk about last week. This week, we're going to dive into stim medications, IVF medications, injections, shots, and talk about common mistakes that we see, give you some tips and tricks. Really all things fertility medications and injections from 2 fertility nurses that have supported patients across the country navigating their injections. And so hopefully, I hope this really resonates with each and every one of you. And for those who are navigating or about to navigate a fertility cycle, treatment cycle, IVF, that this is helpful for you because we're going to kind of give you our brain when it comes to injections and medications. And hopefully you feel a little less anxiety about doing the medications. And that's obviously one of our goals, because I do think that the medication piece is one of the most intimidating parts about a treatment cycle or about IVF in general, for many people, whether that's needle anxiety, whether that's just fear of doing something wrong. I think a lot of people that go through IVF, you're not a medical professional. You know, there's us that have been trained to do this stuff and are around needles all the time and mixing things. Yeah, sure. We're pretty comfortable with it. But there's so many people out there that you're like, wait, you're asking me to do this? You're asking me to do what? Like, I have to mix this? I have to inject this? And that can be really overwhelming. So I hope that this helps.
Yeah, I'm really excited about this one. I love talking about all things medications. I think that you and I have both seen a lot of different things like in our careers. And I think, it's very overwhelming. If you've never manipulated a needle before and then all of a sudden this box shows up at your door, and it is a lot. I mean, you get bags of needles, you get like 4 or 5 different medications, sometimes even more than that. Yeah. Some require mixing, some require dialing on a pen. A lot of them are taken at different times. Yeah. There are drugs that maybe your clinic prescribed you one drug, but what your insurance gives you is its equivalent. And then you're confused because your instructions say one, but you have the other. Yes. So it can get really confusing really, really fast. And there's a ton of resources out there on the internet. There's some really good ones and there's some really not so great ones. But I love talking about all things medications. Yeah. And so I guess, where do we kind of want to dive in and start talking? Do we want to just kind of review like a typical IVF cycle and kind of the common drugs that you might see?
Yeah, I think we just demystify the meds a little bit, right? Like, let's talk a little bit about what medications you're taking and the why behind them. They all have a reason. Yeah. They all have a purpose. We don't ask you to take, 4 shots for fun. That's not our job. It's to make you really miserable and doing a bunch of injections and bruising and all that kind of stuff. That's not what we're trying to do. They really do all have a purpose, I promise.
Yes.
But yeah, I think we start there. I think we demystify what medications and hormones you all are taking.
Yeah. Yeah. And I think Ashlee and I pointed this out on a previous episode, but I think the first most important thing to point out is that the hormones that you are taking, right, are not some random concoction of pharmaceuticals that we use for IVF. These are hormones that your body makes naturally every month. So if we think about the basic menstrual cycle and we split it into 2 phases, we have what's called the follicular phase, which is the first, in a 28-day cycle, the first 14 days. And your body is producing a hormone called FSH to stimulate your ovaries and to mature an egg. And so the medications that we're giving in IVF are typically just a higher dose of FSH, because in a normal menstrual cycle, we're trying to get one follicle to grow. In an IVF cycle, we're trying to get every available follicle you have. And I know we kind of explained this in a previous episode, but if you didn't listen, as women, we go through a cohort or a group of eggs every single month. We're just going to say that averages, if you're in your late 20s, early 30s, somewhere between 10 and 20 follicles a month. And you're losing 10 or 20 follicles a month, whether or not you're doing IVF or not. So a lot of concerns I get, or, if somebody's doing an IVF or they're egg freezing, is, am I depleting my entire egg supply? No, you were going to lose those 10 to 20 anyways. So again, in a normal month, in a natural month, your brain, your pituitary gland in your brain is sending down FSH to stimulate those ovaries to get 1 or 2 follicles to mature. Now we're giving you that same hormone in the form of these medications combined with LH, which is another hormone that works very similarly, to try to get every egg in that group that month to become mature so we can retrieve it.
Yeah. I like to think of the way I describe FSH, or follicle stimulating hormone, is follicle food. And I think of our follicles
I'm never going to think of it another way now.
As cookie monsters. So I know this is how I describe it.
Oh my God, I love it.
So our follicles are, like Laura just said, ideally we're grabbing 1 to 2 every month to ovulate, and we lose the rest of them. So if we give you more FSH, if we give you more follicle food, and those receptors on the follicles are open, those cookie monsters, those follicles are going to grab on to the extra FSH, and we're going to grow multiple follicles. So that's what I like to think about it with FSH. It's follicle food, and our follicles are cookie monsters grabbing on to all of that.
No, I love that, because actually, this is a really good visual. And I'm kind of putting what you're saying with the visual that I've often given people to describe what an ovary looks like on an ultrasound. It looks like a chocolate chip cookie.
Yes, yes.
So when you look at an ovary on an ultrasound, I mean, you and I have looked at many ultrasounds. It's really easy for us to call out and what we're seeing. But if you're ever in the ultrasound room and you can see the screen, you should kind of see like this chocolate chip cookie, the shape, and the little black spaces, those are the chocolate chips. And the more that you have, those are all the follicles that you have that month. So, and now I'm like, oh, cookie food. Like, I love it.
Yeah, but that's just an easy way to think about it. If you have just what your body's giving you, if you have just the FSH your body's giving you enough follicle food to grow 1, maybe 2 follicles in that month. If we give you more follicle food, more FSH, the more follicles that we can grow that are recruiting that month. So that's kind of like what I like to describe it. And so the medication that correlates with these, that some of you may have already been taken or potentially are prescribed or about to start, this is going to be your Gonal-F, your Follistim, and your Menopur. Are the most common medications that are going to have FSH. Now, Follistim and Gonal-F are just FSH, just follicle stimulating hormone. Those are the exact same medication, just different name brands.
Yes.
So Follistim and Gonal-F can absolutely be interchangeable. So you can get whatever your insurance covers, get whatever's cheaper, or obviously whatever your provider, if they do have a preference or a recommendation of which one to do. But essentially they are the same. You're not going to be taking both. No. You're going to do one or the other as that main follicle food, that main FSH. And then Menopur, which I know a lot of people hear a lot about, which we'll get more into, is mainly FSH and a little bit of LH, so luteinizing hormone. And luteinizing hormone is what our body pushes out at the end of that follicular stage to push out and promote ovulation. So we give a little bit of that LH because we're growing more follicles. We're going to need a little extra LH at the end to promote quote unquote ovulation. Now, obviously in an IVF cycle and an egg freezing cycle, we will trigger ovulation, which we'll get more into. I'm getting a little ahead of myself, but we'll trigger ovulation, but we don't let you actually ovulate. So some people ask, like, why do we need LH if we're not going to we don't really want you to ovulate. It's because our body's naturally pushing that out a little bit from our brain, from our pituitary anyways.
Yep.
And the more follicles we grow, we're going to need a little extra. So we give you a little bit of that LH in the Menopur to sort of mimic that little extra that you're going to need.
Yep. Yeah. And to talk a little bit about, how these drugs are prescribed. So most of the time you're going to receive it in the form of an injectable pen. If you've ever seen a insulin pen, it's very similar to that. There's going to be a pen with the medication. For Gonal-f, it's just a pre-filled pen. For Follistim, it's a little cartridge that you load into a pen device. And you turn the dial on this pen up to your prescribed dose to administer it.
Yeah.
I think the other thing to kind of call out is that there is sometimes I've seen people order the Follistim. I don't think Gonal-f, does Gonal-f have a pre-fill? Oh, it does, where you can mix it.
It does have vials. Yeah,
yes,
there is a version of Gonal-f that you do have to mix versus the pen version. But I do think most people get the pen.
Most people get the pens. Yeah, I have seen it a few times with the vials. But most of the time, you're going to be receiving it in the pen. And then unfortunately, as of right now, Menopur is only in vials. I know there was an initiative, like a few years ago, and I wonder if it's still being worked on, where you can actually get Menopur in a pen. I haven't heard any updates. I haven't seen anything coming out, but I know that we would all love if Menopur did come in a pen.
Yes. And the reason for that, I think we get this question a lot, not to cut you off, but
no, please.
I get this question a lot of, can I go ahead and mix my medication in advance? So Menopur, you do have to take liquid in a powder, depending on your dose. There's different numbers of vials you have to use, and you mix the liquid with the powder to make your dilution. The question we get a lot is, can I go ahead and mix all these ahead of time and just put them in my fridge or something like that? And absolutely, with the way that Menopur is right now, you do not want to do that, because Menopur starts to lose its efficacy about 30 minutes. It starts breaking down. So you want to really mix and administer that medication right away. So you don't lose its efficacy. It doesn't lose its little oomph that it's going to actually give you and do what it needs to do. Yeah. And I think that's a really important call out, because we get that question a lot. And I think a lot of people, that'd be ideal. Just go ahead and mix it, and then you're done. You don't have to worry about it, instead of mixing it every single day. Yeah. But that's also the reason it's not in a pen form right now, because scientists, not us, chemists, whoever's doing this, pharmaceuticals, we haven't figured out how to make it stable enough to be in its mixed form and not lose its efficacy.
Yeah. And let's talk a little bit about the storage of these two medications. So Menopur can be stored unmixed at room temperature. You do not need to put it in the refrigerator. It's simply a powder and then just a simple saline solution. So no refrigeration needed. Follistim and Gonal-f, what I always tell people is if you keep it in the refrigerator, it's good until the expiration date on the box. Once that Gonal-f or Follistim is used for the first time, you have to throw it out in 30 days. Yeah. Because it's been opened. Yeah. And Follistim or Gonal-f is actually stable at room temperature for 90 days. So I tell people, you could just keep it in the fridge the entire time that you're going through the cycle. That's probably the easiest. But it also then requires taking it out of the refrigerator for, 15, 30 minutes beforehand to let it come to room temperature before you administer it. It can help reduce a little bit of discomfort with the injection. So what I tell people is, if you want to keep it out of the refrigerator, just keep the opened one. So if you've started using a pen, once you've used it, fine, go ahead and keep it out. Otherwise, keep it in your refrigerator so that it's good until the expiration date.
Yeah. And I think that's a really important call out, because I think a lot of people think they've made a mistake if they've left their pen out.
Yes.
Because it's so confusing. It's not, it needs to be in the fridge. It's fine at room temperature. You could keep it in the fridge and it's going to keep it whatever. Oh, it's good out of the fridge for 90 days. And you're like, well, we just want straightforward answers. We just want to know what to do. I don't want to have to decide how I store the medication. So I think that's a really good call out. That's a mistake that we hear sometimes is, that I accidentally left my pen out, and it's actually perfectly fine. Yeah. So great call out.
Yeah. And there are some medications where if you did leave it out, they have to unfortunately be tossed. But this is follistim and Gonalaf are not one of those.
Yeah.
Okay. So we're giving you this follistim, this Gonalaf, usually it's one or the other. And then with Menopur, sometimes it's Menopur alone, or sometimes it's Gonalaf or follistim alone. There's I think we've talked about this before. It's like a recipe. There's a ton of different ways that these medications can be used. Sometimes you'll do morning and evening. Sometimes you'll do one in the morning, one in the evening. Sometimes you'll do them both in the evening. There's a whole bunch of different ways that these medications can be prescribed. So one, if you have a friend who's doing it and you're doing it and it looks different, that's completely normal.
Yeah. And before we kind of continue on our cycle and move forward to some other medications, I do want to tell the Menopur story.
Okay. I think I know where this is going.
Laura and I were talking about this beforehand. It's a fun story to tell. This is knowledge that you will probably never need to use ever again, but we like to tell it because it's a funny story. So like we talked about, Menopur is mainly FSH with a little bit of that LH. And how we used to get LH, or luteinizing hormone, instead of manufacturing it, we would actually get it from postmenopausal nuns from their urine.
Yes. So it'd be diluted out of that urine.
So if we think about it, if you think about, we're doing an LH strip or an ovulation predictor kit at home, and we're trying to track ovulation, we urinate LH, which is how we can detect it on the strip. So how we used to get it way back in the day for fertility treatment and creating Menopur is we would get urine from postmenopausal nuns because they assumed it was pure, I guess, because they're nuns. I don't know the backstory.
Yeah, I don't know the
messing up some of this, but it's just a funny story to tell, just because that's how we used to get it. We do not do that anymore, so everybody can breathe now that you're not injecting a powdered urine from nuns anymore. We do now manufacture it, but it's a fun story and we like to tell it. And so now you have a very useless fact that you can share with other people if you would like.
Yeah. Maybe it's on a Trivial Pursuit, and it's someday when you're playing, that'll be the winning question.
Yes. And thank us later.
Yes. I guess actually one other thing I want to point out with follistim and Gonalaf is these pens can come in 3 different sizes. So for follistim, it'll come in 3 different cartridge sizes, 300, 600, or 900. Gonalaf comes in 3 pen sizes. It's a little different. It comes in 300, 450, or 900. So Gonalaf doesn't have that 600. Actually, I think it's their pre-filled or the vials, I think are those 600, or they might be 450. Why it's different, I don't know. But the other thing that I like to tell people is there's actually a little bit of overfill in all of the pens and all of the cartridges. So for instance, if you have a 300 IU cartridge or pen of Gonalaf or follistim, it actually probably has closer to 400. I always say 100 to 150 IU of overfill in it. And this can cause sometimes confusion for patients in a couple of different ways. One being, let's say you have a 300 IU pen and you dial it up to 300 and you inject, and then you see the little window, you can actually see liquid in the pen and you still see liquid remaining. I've actually had people make mistakes and think, oh my gosh, the pen was faulty. I did not get my entire dose. And now they've overdosed themselves. Yeah. So that's one thing I like to point out, is that it's normal to have a little bit extra. There's different ways that you can use that extra, either doing a second injection the next day with the little bit that you have left, but it does require you to do 2 injections in a row. And there's a whole process that we could talk about and how to do that. I don't know that we'll get into that here. But there's also, I think, I've seen people just throw that out. Yeah. And if you're self-pay for these medications, it's pretty expensive per 75 IU of these medications. So if there's 100 to 150 in there, that's $200 for self-pay medication. So there's ways that you can use that. Sometimes clinics will draw it up into an additional syringe, so you get an additional dose, but I just wanted to kind of point that out.
No, I think that's really important, especially for our self-pay patients out there that if there's some extra that you can use and you don't have to buy another cartridge or another pen, that saves you hundreds of dollars, and you're spending so much already on this process. So I think the overfill is not talked about enough. I think the different sizes of cartridges is not talked about enough, because, you know, we'll order usually the biggest ones because you're going to use it, right? A lot of times we're just ordering the 900s for you, but we never really talk about like, oh, you only need 300 for like one more dose or something, that you don't have to buy another 900 unit pen. You actually can have your clinic prescribe you the 300. And again, if you're paying out of pocket, that saves you hundreds of dollars. So I think that's a huge call out. I think another thing with the pens that I'll mention is again, not a mistake, but like that we get a lot of questions about, is those pens are not smart enough to tell you what the dose is, right? And you can't really see on like the lines, like where exactly. Yeah, you see,
and it's not accurate.
And it's not accurate.
It's not accurate.
You don't like it. It's not smart enough, and it's not going to alert you when you're getting low. So a tip that I like to tell people is, you know, you're going to have to keep track of this. So, you know, if you have a 900 unit cartridge and your dose is 150, put it in your phone, sticky note on the fridge, however works for you, and just start subtracting so you know when you get down. And then when you only have a certain amount left, but your dose is higher than that, you're going to want to switch to a new pen or a new cartridge. If you forget and don't do that, or you're not tracking, what can happen sometimes is, again, it'll still let you dial to your dose because it's not smart enough to know there's not enough liquid or medication in there. So you can start pressing, you're doing your injection, and it stops. You can't push any further, and it's not at zero. It's not all the way down. And so you haven't given yourself the full dose of medication. And I've had people like, oh my gosh, what do I do? Especially if, you know, you maybe don't have another pen or another cartridge. How much, like, people in that moment, it's very anxiety inducing. You weren't expecting that pen not to go all the way down. So it's like, oh my goodness, what did I miss? How much do I have to still give? Things like that. So if that happens to you, you're not keeping track, it stops. Whatever it shows in that window is the amount you didn't get.
Correct.
So let's say you dialed to 150 as your dose, you inject it and it stops at 50. You gave yourself 100 units and you're missing that 50 units. So hopefully you have another pen or another cartridge. You would just get a new pen, new cartridge, new needle.
New needle. Yes. Don't use the same one.
In a different spot. And you would inject 50 units to get the remaining dose that you needed. So I think that's another call out that's really important to make, tip that I tell a lot of patients. So, because that can be very anxiety inducing when the pen just stops.
Yes.
And you're like, oh, wait a second, I didn't get my full dose. Now what do I do?
Well, I think that's important then. I think that's important in saying also that whenever you're administering either one of these medications, make sure that every time that you finish your dose, that pen is reading zero. So it should always be back at zero to confirm that you got the full amount. And the way that you just explained, like what happens if it does stop and you need to give yourself additional, is also the way, right? It's the same process. If you do have that overfill and you want to just use it right away and not save it, and I'll talk a little bit about one of the benefits of doing it this way. But if you want to just continue to use that overfill, right? Give your follicles in your example of your dose is 150. It reads 50 after you've finished out that first pen. Grab a new one, administer the remaining 50. The reason I say, it requires giving yourself a second injection that night. But what I have seen people do, again, especially if you're self-pay for these medications, is I've seen people save all the overfill and then use it at the end. And that can work. The problem that could come about is I've seen people's cycles get canceled. And now they've saved all this overfill. And remember what I said at the beginning is it's only good for 30 days once you've used it for the first time. More than likely, you're going to have to throw it all out now and start fresh with the next cycle because that 30 days will have passed. So that can be a benefit of just using the overfill right away before going to a new cartridge. If you're not self-pay, probably you can do it the other way. And if you have to throw some out, not a big deal. Or if you're really needle averse and you don't want to, I think also the other thing I'll say, and this would be something that, you would have to talk to your clinic about, but I have seen some clinics tell people to use their follistim or their Gonal-f to mix their Menopur, to combine it into a single injection rather than multiple. There can be some issues with that, and the amount of liquid that is in the follistim dose may not be enough to mix the Menopur, so then you still have to add in some saline. So it can complicate things. So if that is something, if you're really, really needle averse, you're very nervous about injections, you could ask your clinic if that's something they're comfortable with and how they would instruct you to do that mixing.
Yeah, I've seen this come up more and more. It was very like taboo, don't mix any of the medications together. And that's usually what, as nurses, we say.
Right.
And I think pharmacists would probably agree and
Yes.
maybe don't love that we're mixing that, saying that. But there are some providers out there, there are some clinics out there that are okay with mixing, the two Menopur, Gonal-f, follistim together. But please don't do this on your own.
Yes.
Please follow your clinic's instructions. But it absolutely, if it's something you want to ask about and advocate for, you absolutely can do it and get what your clinic's response would be. And so we've talked a lot about Gonal-f and follistim and given you a lot sort of like our tips and tricks and common mistakes we see there. I think something I'll say about Menopur, I don't think Laura and I are going to dive into mixing Menopur very, very much because every clinic has different mixing instructions and your dose changes the mixing instructions. So we're not going to go down that rabbit hole. If that's something that would be useful to anyone and we need to have a bigger episode on Menopur or mixing, let us know in the comments. Happy to do something additional.
Yeah.
But Menopur essentially is you're taking saline liquid and you're mixing it with powder. Okay. And you there's different ways to do that. And so we'll leave that up to the clinic to give you those instructions. But what I do want to call out as a common quote unquote mistake, again, a lot of these things we're talking about aren't like mistakes.
They're not mistakes. Right.
It's just, and a lot of times mistakes are something that we can fix or something that doesn't jeopardize your cycle.
Yeah.
So when we're saying these, it's not mistakes. It's just things we hear and questions and things that come up that maybe aren't, okay, you didn't do perfect end to end like you see in a video or something like that. Mm-hmm. When you are mixing the Menopur and you're mixing liquid with powder, especially the more powder vials that you're using, when you get to the end and you're getting ready to inject, you may notice that your liquid looks a little less than what you initially started out with. So let's say you mixed with 1 ml of saline to mix your powder vials. When you get to the end, you may notice that it looks a little less than 1 ml in your syringe. And that question comes up a lot, the people thinking like, I didn't get all of the medication out of the vial. I mixed something wrong. And that's not true. One, the powder's going to absorb a little bit. So you're just going to lose not lose volume. It's just absorbing into that powder.
Right.
And when you think about it, when you prime your needle to get rid of any air bubbles or things like that, when you're doing your injection, you push a little bit up into that little needle at the top. So it's no longer in your syringe.
Yeah.
So your syringe is going to measure a little bit less.
Yeah.
So I think that's a really important call out that you all are not doing anything wrong if you see that a little less than that 1 ml or whatever your dilutant dose is, that it's normal. That's going to happen. Don't freak out about it. You did everything, I'm sure, correctly.
Yeah, I think, Menopur's probably one of the trickiest medications that are prescribed during an IVF cycle because of that mixing.
Yeah.
And so I think, as you said, we could go down a huge rabbit hole with Menopur and the different ways to mix it and different ways to expel air bubbles and all the things.
Yeah.
So we won't go there. I think, moving on to like the additional medications in a cycle. So you've got your Gonal-f or follistim and your Menopur, a combination of 1 or 2 of those. Usually, right? So because we're stimulate all of these eggs to develop, what happens is your estrogen starts to rise really, really rapidly. And that rise in estrogen is actually in a normal month, what would signal to your brain, hey, we've got a mature egg. It's time to, throw down some LH at those ovaries so that you ovulate. In an IVF cycle, obviously, the goal is that we are triggering or we are timing when that ovulation is occurring. So we need to prevent that ovulation from happening. So during your IVF cycle, Usually around, I say day 5, 6, 7, somewhere in there, your clinic will be having you take something that's going to prevent ovulation. There's again, in our recipe, there's different ways that we can do this. So there's something called luteal Lupron, and then there's ganirelix or cetrotide. I've seen progesterone being used, like a Provera. That's something that I'm seeing more and more, I think, from a cost perspective, to prevent ovulation. But most commonly, two of the most common drugs that you're going to see are either ganirelix or cetrotide. And just like our follistim and argonal F, cetrotide and ganirelix are the same medication, just manufactured differently. Now, each one is given a little bit. So whereas like follistim and gonal F, they're both pens. Granted, one's in a cartridge you put in a pen. Cetrotide and ganirelix are a little different. Ganirelix is a pre-filled syringe where really the only preparation you do for that one is there's like a little air bubble in it that you expel before you inject. Cetrotide does require some mixing and combination of a powder and a liquid. It's not as complicated, I would say, as like a Menopur. There is some mixing involved. One thing I always like to call out with this medication in particular, especially ganirelix, is there's a little additive in the ganirelix that I often see cause some irritation at the injection site afterwards, a little redness, some itching. This was something that I experienced, and I've seen a lot of patients experience. You're not having like an anaphylactic reaction. If that occurs, this is really common. And usually that redness, that itching resolves within, 10, 20 minutes after the injection has been given. So if you do see that happen, like it's not abnormal. I don't see it as much with cetrotide. I think there's some additive in the ganirelix that causes that reaction.
For some reason, the ganirelix needle, I feel like, is a little more dull.
Yes, I think you're correct. I've had people tell me it's harder to push it.
Pro tip to everyone out there, you kind of have to do a little bit more force on that ganirelix needle for some reason. I actually have seen with cetrotide, people get just little minor welts.
Okay, so same thing.
Yeah, so it's the same thing. There's got to be some additive in that. It's called an antagonist medication when we're talking about these medications that suppress or stop ovulation from occurring. There's got to be something in the mixing and processing of it that causes. So yeah, with either of those, ganirelix, cetrotide, if you notice a little welt, little itching, little like raised area redness, know that it goes away. If it doesn't in 30 minutes to an hour, spreads get worse, obviously contact your provider. But for most people, it's normal. And it's usually just with the first one. And then after, it gets a little bit better, or I guess maybe you just know to expect it. So it's
maybe it's that. I was going to say, I don't think it ever got better for me. I think I had it every single time. One of the things that I used to do, and again, you would want to talk to your clinic, but sometimes some topical Benadryl, like the little, the stuff that you put on bug bites, can just help calm that reaction down. But again, you would absolutely want to talk to your clinic about that. I want to go back real quick to Menopur. One thing that we didn't call out is that when you inject Menopur, it is not uncommon to have a little bit of burning after the injection from that saline solution. Can cause a little bit of a sting. Again, that usually resolves within like 30 seconds to a minute. It's pretty short-lived, but that's not abnormal. That's pretty expected. One kind of like pro tip I give people, whether it's, Menopur to help with the burning or ganirelix to help with that little reaction afterwards, any of these medications, I tell people to put a little ice pack on your stomach for like 30 seconds prior to injecting. It just numbs up the surface of the skin so that most people don't really feel the injection at all. I find that I've done a lot of virtual medication trainings with people, or even in person, and most people are pleasantly surprised. You build up in your head, oh my gosh, I'm giving myself an injection. This is going to be horrible. And then they do it and it's like, oh my gosh, that was nothing. Again, it's not everybody's experience, but I would say for the most part, I think we build these up in our head to be something really horrible, and they're actually pretty easy. And when we're talking, I think we've mentioned the word subcutaneous a few times. So that just means going in the skin, fatty tissue layer of the skin. So it's like not even a 1/2 inch long needle. It's usually like, I don't know. We'll just say a 1/2 inch, but
usually it's around 1/2 inch.
It's like around that.
No, I think that's a really good call out. That Yeah, that's just such a good call out. And another thing I'll mention since we're talking about subcutaneous is I think a lot of people, so most of the time, if you're doing a subcutaneous injection, you're injecting in the lower abdomen, right? Anywhere you can pinch an inch of fatty tissue, the abdomen tends to be the best subcutaneous location. We tend to carry a little bit more fat there. The absorption tends to be a little bit better, so that's why you'll see, abdominal injections for subcutaneous. I lost my train of thought completely. Oh my gosh, this is terrible.
We'll cut this out.
We did this not that long ago. Oh my goodness. That is awful.
Hey, we don't have a lot of errors that we have to splice out. So,
where was I going with that? Any idea where I would have gone with that?
I don't know. You can do the back of the arm or the upper outer corner of the thigh. I have seen clinics tell patients.
Now I know. Where did I even begin with that? So it's easy for you to like edit it or put it in. I can just, where did I start from the beginning? I'll just start from like, that's a really good call out, like I said, and keep going.
Okay.
I think that's a really good call out because, and I'll just talk a little bit more about subcutaneous injections here is, most of the time when we're doing a subcutaneous injection, we're injecting into the lower abdomen. So the fatty tissue of the lower abdomen. There are other locations you can do a subcutaneous injection. Obviously check with your clinic if you want to inject in one of those other locations, but we go into the fatty tissue of the lower abdomen because we tend to carry more fat there and absorption tends to be a little bit better. But what I see a lot of people do is when you're doing multiple injections, right? So now we've already talked about Gonal-f and Follistim, and we've talked about Menopur. And now we're adding another injection, maybe Ganirelix or Cetrotide or something like that to stop ovulation. I think a lot of people get in their mindset that, I'm going to inject all this on the right side one day and then all of this, and then the next day I have to make sure to inject on the left side because we're targeting an ovary, right? I think a lot of people get in their head like, I have to do this side and this side because I'm targeting my ovaries.
Yeah.
And the realistic side of that is, yes, move around, use your surface area, inject everywhere because bruising and soreness and all that kind of stuff. But we are not, yes, we're targeting the ovaries, but just because you inject on one side versus the other.
Yeah, it doesn't make a difference.
Matter. It's going into the fatty tissue. It's going to go all over your body. And then it's going to get where it needs to get to do what it needs to do. So don't get too caught up in, I injected on this side and then I have to inject on this side. And if you mess that up,
it doesn't matter.
Yeah. So easing everyone's anxiety that like, yes, move around, use your surface area. That's for multiple reasons, but we're not like targeting a specific ovary each time you're doing those injections.
Yeah, no, that's a good call out. I usually do the one side to other side by day more because you're doing so many injections, you're giving that, like the way that I think is ideal, and there's a ton of different ways, right? You can, I say draw a crisscross through your belly button. You've got 4 different quadrants you can inject in, or draw a smiley under your belly button, and you could kind of like go around the belly button. The way that I've kind of taught is right and left lower quadrants, do them all on the same side one day, and then the next day switch to the other side so that we're giving that other side a full day's break before we're back to it. I think can help a little bit with that discomfort rather than like doing Ganirelix on one side and Menopur on the other side and Gonal-f on the other, right? Then we're constantly like sore and bruising in those areas. So it just kind of helps. I mean, again, it's theoretical, but in my mind, I'm like, that's just like helping that other side just like recover for a day before we're going back. Yeah. I think people freak out too if they get bruising or they get bleeding, right? Or they get like sometimes you can get a little bit of bleeding under the skin. What I try to remind people is subcutaneous tissue, that fatty tissue. We think of blood vessels, we think of veins, we think of arteries, but we also have what's called capillaries, and they live just under the surface of the skin, and there's tons of them, and it's very easy that we nick one of those capillaries when we're going through the tissue. That's where that bruising comes from. You didn't like inject into a vein or an artery or anything like that. And I want to call out here too, because I'm kind of like giggling in my mind as I'm talking about this. So we get very hung up because I think TV has portrayed like if you inject air into somebody's IV line, you will kill them, right? It's an air embolus. So people see bubbles in their Menopur after they mix, or their ganirelix or whatever.
Yeah.
And I've seen people spend hours trying to get rid of these little teeny tiny air bubbles.
Yep.
Air is not harmful to inject into tissue, right? Like, we don't want to be injecting a ton of air because that's going to cause discomfort. But there literally are injections like Lovenox, which can be a part of some IVF protocols. There is air in a Lovenox syringe. And the whole point of Lovenox is that air bubble goes in last to prevent it from coming out. So injecting air into tissue is not harmful. I like to try to eliminate air just to make sure our dosing, especially for Menopur, is correct. Like, our measurement is right. But if you have a little air bubble, like, you're not going to kill your significant other if you're the one injecting them. It's not a huge deal.
Yeah. No, I think that's a huge one. I think a lot of people, exactly right. TV, movies, it just shows this tiny air bubble going directly into the vein. And then all of a sudden that person's coding, and that's not real life.
No.
So don't freak out about air bubbles. Do the best you can to get rid of it. Sometimes they're stubborn. They just aren't going away, and just know that you're not causing harm if you notice some air bubbles that you injected in.
Yeah.
I think, I don't think this happens very often, but it is something both you and I have seen separately. So I do think it's important to call out. When we do a subcutaneous injection, Laura mentioned, we're using about a 1/2 inch long needle. So it's pretty short. You are going to get some potentially longer needles in your medication box because sometimes you mix or trigger with a longer needle, and you do an intramuscular injection, which requires at least usually a 1 inch long needle.
Yep.
I have seen in Laura as well where people have accidentally injected in their abdomen subcutaneously, or I guess not subcutaneously, but in the abdomen with a medication that's supposed to be with the shorter needle. They use the longer needle, inject into the abdomen on accident.
Mm-hmm.
So one, that's just super painful. Please avoid doing that if you're listening to this. Two, we also just want you to know, again, that's one of those quote unquote mistakes that's not going to cause harm to your cycle.
No, it's just going to hurt.
It's just going to hurt.
Yeah.
We will correct you and say, nope, you need to use those shorter needles and inject into the abdomen. But just calling that out, again, it doesn't happen super frequently. Most people are very cognizant about the size of the needles.
Yes.
But we have seen it happen, especially sometimes, like, let's say the pharmacy didn't send you the right size needles and all you got were the longer ones on accident. I've had that happen.
Yep.
Pharmacists are human too. And maybe or nurses ordered something wrong. You never know. And then again, you getting this box, you're just getting a bunch of needles, so you think that's what you're supposed to inject with. So always ask questions if you're seeing anything like that. No, you're not causing harm other than it's more painful, but you're not causing harm to the actual cycle if that does happen.
Yeah. I'll say there on that note, that's a good reason also to do an inventory of your medications when they arrive. I see, especially with Menopur, where the pharmacy will package, you get usually syringes with needles attached. Sometimes they don't come with the needles attached, but more often than not that you get the syringe with a long needle attached. And in that same bag, there'll be a smaller bag with the smaller needles that you're actually using to inject the Menopur. And I've gotten on many calls with people where they're like, I don't have that needle. And I'm like, go check the bag where you pulled out the long syringe. And then they inevitably go and they're like, oh yeah, they were in there. So I think it's an important when you get your list from the pharmacy. I mean, there are times where maybe the pharmacy made a mistake. I would say that's probably rare, or if the nurses didn't order the right ones, again, probably rare. So you should, with your pharmacy order, get an invoice or like a list that shows you everything you should have with the quantities. Go through when that box arrives and double check that you have everything that you need, so that come that first night injections, it's not a panic moment of, oh my gosh, I don't have that thing. Sometimes that does happen. I've had people, like Stim, for instance, it's a cartridge and a pen device. I've had people get the cartridges and the pen device wasn't included. And that can happen sometimes if it gets ordered wrong, or the pharmacy already thinks you have a pen from a prior cycle, so they just don't send you another one. So again, pro tip, look through your medications, count everything when you get it.
Yeah. No, that's a big one. And I think something else, since you're talking about unboxing and sort of med organization, I think something a lot of people are seeing on social media is, people getting these sort of like tackle boxes. Have you seen that?
Caboodles. They're like
Caboodles.
caboodles. Do you remember caboodle?
Yes. Oh my gosh, that's a blast from the past. Okay, caboodles or tackle box or something, and they're organizing their meds in there. And that absolutely, if you are a super type A organized person and you want everything, and I've even seen people like label the stuff, like get a little label maker and you label like this goes with this goes with this. I love it if that works for you. I do just want to call out if you're like, wow, that stresses me out even more that I now have to buy something extra and organize it. Please know that, again, that's something just that works for some people, may not work for you. It is not required that you have this perfectly organized situation, but I do think inventory, very, very important. And then however you are comfortable storing and you know what goes with what, perfectly fine to do you.
Yeah, totally. Okay. So I mean, we've got Menopur, Gonal-f, Follistim, Cetrotide, organolerics, right? Those are the main medications. Again, we're not going to go into all of these. Sometimes there's Omnitrope. Sometimes there's Lupron. Sometimes there's pills, right? There may be Clomid, there may be dexamethasone, there may be letrozole, right? All of these things can be in addition to that protocol, that recipe, if you listen to our prior episode. But I would say those are the core that we've covered before we get to the kind of the trigger shot, that final injection. Go ahead.
Before we move forward, I do just, because you mentioned storage of the other two and we didn't really talk about, I do want to call it out really quickly because this one's a weird one.
Yeah.
So ganirelix that we've talked about, pre-filled syringe, that is actually room temperature. Yeah. Keep it out, perfectly fine to keep it at room temperature. Cetrotide, which is the powder and the liquid, which again, Menopur is a powder and a liquid, and that's room temperature. Cetrotide is a powder and a liquid that you have to mix, but it is refrigerated. So this just adds to the confusion even more if you're a patient and you're not used to these medications of like what goes where. Yeah. So important to keep that just distinction in mind. And as Laura mentioned, one of the things that helps with discomfort with any refrigerated meds is, and it's a sort of a pro nursing tip, it's fine to just take it out and inject. You're not doing anything wrong.
It doesn't decrease the efficacy. I've had people be like, how long do I need to keep it out? 15 minutes to get to room temperature, but if you do it right away, it's fine.
It's for comfort. Sometimes cold medication going into tissue just hurts a little bit more, just has a little bit more discomfort. So we just tell you to do that just so it doesn't hurt so much. And we don't want you to hurt so much. So before we kind of went on and started talking, I just wanted to throw out storage because we did mention it with
you're right. Thank you for bringing that up. Actually, and I want to go back to my comment about icing the injection site before. I think I said 30 seconds. Please do not put an ice pack on and leave it there for minutes. Because then you will give yourself an ice burn, and then that's like a whole nother level of discomfort.
Yes.
So again, no more than 30 seconds is all you need to just kind of numb up the surface of the skin before you inject. I think just like to put that out there. I've seen people leave it on for too long. And I like those, you can get those little circular ones, right? You can get those, I like the beaded gel packs that you can buy at CVS or Walgreens. CVS even exists anymore. I don't know. Target, Walmart, your local pharmacy. Because those can be heated or cooled down. And again, I don't want to go too long, but heated can be really good for later injections like progesterone and oil.
Yeah. Talk about tips and comfort, I think, at the end, just like general. But yeah, I agree with you. I've seen people get, I call it freezer burn. It's not freezer burn. It's
ice pack burn.
I've seen it, and it's really uncomfortable. And then like you can't even really inject into that area very well. There are some clinics that do not advise ice or are pretty strict about saying no ice. So I will just call that out. If your clinic is saying that, they're really saying like they don't want you to ice for too long.
Right.
But there is another trick. I don't know if you've seen this, Laura. Have you heard of Buzzy Bee?
Yes, it's like that. It's like it's like a buzzing stimulation to kind of like throw the nerves off. Yeah, I have seen this.
We're not. This is not like a sponsored anything, but and because this is a specific brand. It's called Buzzy Bee. You can get it on Amazon. You can use any sort of vibrating device, but the theory is, especially for those who don't want to do ice or maybe your clinic's pretty strong against it, It's this little vibrating bee, and you stick it over the area you're going to do your injection, and it tricks you can keep it on as long as you want to, it doesn't matter. It tricks your nerves into feeling, if you like something's vibrating for a really long time and then it stops,
you still feel the vibration.
Yeah. So it sort of tricks your nerves. So when you do your injection, your nerves are still already tingling, and you don't feel the needle prick quite so much. So that's a trick I tell people who maybe don't want to use ice, are nervous about it, or their clinic is pretty adamant about not using it.
Yeah. If you really wanted to, you could ask your clinic to prescribe you topical lidocaine gel, which most local pharmacies carry, and you can pick up with a prescription. The tricky thing with that is you usually have to apply it for like 30 minutes prior to even injecting. I think what I tell most people is, again, I think we build this up in our heads and we think it's going to hurt really bad. And then we do the injections and we're pleasantly surprised it's not as bad as we're thinking. So that one, like if you're, again, really nervous, it's something you could ask about, but it's usually more hassle than it's worth.
Yeah. And expensive.
A
lot of times insurance companies won't pay for it. So it's something additional you're paying out of pocket for, which we want to minimize as much as possible, but 100%.
Yeah.
Okay, I think let's move on to talking about trigger and some tips and tricks and some mistakes that we see there. And then I think we wanted to also touch on progesterone and oil, because I think that's a big one. A lot of people have questions and stuff about.
Yeah, and that's like one of my favorite topics ever. I love progesterone and oil.
So for the trigger, again, as we have said over and over and over again, the trigger is the last step of the IVF stim cycle recipe. So everybody is going to potentially trigger differently. So there are trigger medications such as Ovidril, which is a pre-filled syringe. There are trigger medications that are HCG, also known as Pregnal or Novorel. That is a liquid and a powder that you have to mix. At this point, you're a pro at mixing things. So getting to that point, not as bad, and you're used to it potentially with that Menopur. And then there's also Lupron or leuprolide acetate that can also be used as a trigger by itself or in conjunction with one of the HCG medications, which is known as a dual trigger. So again, I don't think Laura and I are going to go into all the different reasons and different protocols that you would use each of those. I think our goal is just to talk about those medications in general, what they're doing, and some mistakes that we see so you don't make those.
Yeah.
So I think one of the things I'll call out first is that HCG or any trigger medication, actually, let's start here. Any trigger medication is going to trigger ovulation. That's the goal, right? Is we've reached the end. We've given you all this follicle food. We've stopped ovulation for a short time period to keep growing those follicles, to increase the number of mature eggs we hopefully get at the end. Now everything's lined up and it's time to trigger for the egg retrieval. That is timed out very specifically with your egg retrieval. And the goal of any trigger is ovulation, but it also has some other components that I don't think is talked about enough. So yes, we're triggering ovulation and we're timing that egg retrieval to go retrieve those eggs before you ovulate at peak maturity. That's the goal. But it also does a couple of other things. One, it's a last little booster of maturity.
Yep.
So you might see a little mini follicular growth, or those follicles growing just a little bit more, that estrogen going up just a little bit more, to sort of, it kind of gives that last little boost of maturity of any, eggs and that are about to be retrieved. The next thing it does, and this is getting a little technical, but I do just want to throw it out there because it's something. Our eggs actually inside of our follicles. So follicles are the fluid-filled sacs that hold our eggs. Our eggs are actually not free floating in that follicle initially.
This is exactly where my mind was here too.
They actually are stuck to the side of that follicle. So what needs to happen during the ovulation process is it needs to release and become free floating in that follicular fluid and eventually be ovulated on its own and start its travel down the fallopian tube, or for us to actually suck it out with the needle. The egg comes with that fluid because it's free floating in that follicle.
Yep.
So the trigger's not just triggering ovulation. It's a boost of maturity, and it's also making that egg release off of that follicle so we can go extract it seamlessly.
Well, and I think that's right, like that follicle releasing from the wall is a component of ovulation that we don't necessarily think about. We think of a follicle rupturing and the egg being released with that follicle fluid, but actually what it is that follicle, that egg being stuck to that follicle wall and releasing. And so one thing, I mean, this is probably too much of a rabbit hole, so I won't go too far, but if you've ever had where you thought, oh, I was going to get this many eggs retrieved because that's how many follicles were growing, and then it's slightly less. Sometimes if an egg isn't mature, it can't release from that follicle wall. So I've seen things like empty follicles before. It's not necessarily, I mean, maybe there wasn't an egg in there, but sometimes it's just that follicle or that egg didn't release from the follicle wall. So that's a whole topic for another day. I think we could talk for hours on all of this stuff.
Oh, for sure. I mean, yeah, I think this is, again, why we say this every episode too. It's one of the reasons we want to have some of these conversations that just don't get talked about enough. And there is so much, and just our patients are just expected to know all this stuff,
right?
Or just trust their doctors and everything. Of like what's going on and what medication. So I think the more we talk about it and like the more educated people are, we say this knowledge is power. So
I think I want to call out really, I'm sorry, I didn't mean to interrupt you. I want to call out real quick. When we're talking about this egg releasing from the follicle wall, I think clinics are educating, right? Don't take things like ibuprofen, NSAIDs for I don't think that they call it out explicitly, but hopefully it's on instructions somewhere. But I want to point out one of the reasons is for that. Number one, NSAIDs can increase risk of bleeding, and retrievals are a surgical procedure, but actually NSAIDs can also interfere with that egg releasing from the follicle wall. So that is another reason, like if you're somebody who's prone to like migraines or discomfort, like usually Tylenol is the only acceptable pain reliever. So you want to check with your clinic before. This goes for anything that you are taking during IVF treatment. You want to make sure your clinic's aware. And if it's something that you're taking as needed, like a cold medication or a Tylenol or an ibuprofen, you really want to make sure before you put anything in your body that you are talking to the clinic. Because again, they're not explicitly saying don't take this because it could interfere with like your eggs actually being able to be retrieved. But that is one of the reasons that we avoid NSAID use.
Yeah. Again, like everything we educate on and tell you about has a reason. Medications you're taking for a reason. Things, do's and don'ts have a reason, even if they're not necessarily explained to you maybe as much as we would like or you would like. But yeah, there's a reason behind all of it. There's a method to the madness, I promise.
There is. I'll just to finish up on trigger shots. We don't have time to go into every single one. It's important to know some are stored in the fridge, Ovidril. If you have pre-filled Leuprolide syringes, sometimes the pharmacy will actually pre-prepare those Luprons. It's also Leuprolide. Lupron is one of those drugs. It comes in multiple different formulations. Yeah. There's Depo Lupron, microdose Lupron, Leuprolide. It's called Leuprolide or Lupron. So just when we're saying those terms, like it comes in many different formulations. But like HCG, so Pregnil and Novorel, as you said, and again, this is where some confusion comes in. It's another powder and a liquid that don't need to be stored in the refrigerator until it's mixed. And actually, unlike Menopur, where Menopur's not, it like loses its efficacy after that 30 minutes, HCG is the opposite. Once it's mixed, it actually can stay in the refrigerator. The other quick call on HCG is usually, especially with Pregnil, I think Novorel too, the amount of liquid that you get is usually 10 milliliters. And your clinic will give you very specific instructions for how much liquid you are using to dilute the powder. There are multiple different doses and combinations of dosing for Ovidril, Novorel, Pregnil, Leuprolide. Like there's so many different combinations. So it's really important for your trigger shot that you are reviewing those instructions. If you have questions, make sure you're getting in contact with your clinic. As Ashlee pointed out, this is the one medication that has to be given at the exact time that it's prescribed, right? If you're prescribed at 10, right? If it's 10:01, fine. You don't want to be like 10 and I did it at 10:15. Like it really does need to be precise so that we don't take you to retrieval and that ovulation process hasn't begun and those follicles have not, or those eggs have not detached from the follicle wall, or you take it too early. Now you go into the retrieval and you've ovulated. It is very time specific to when we know we can go in and those eggs are going to be at that point where we can actually draw them out.
Yeah.
So
And I'll just call out really quick for HCG specifically. A lot of times, again, we've talked a lot about subcutaneous injections, and I think this will be a really, well, I have 2 more points on HCG and then we'll go to progesterone and oil.
Yeah.
But that it can be, we talked a lot about subcutaneous. HCG can absolutely be subcutaneous. Avidril is pretty much always subcutaneous. Lupron or Leuprolide, if you trigger with that, almost always subcutaneous. HCG, Novarel, Pregnol, can be given subcutaneous. Some clinics do it subcutaneously. Other clinics will have you administer that one medication intramuscularly, meaning you use slightly longer needle, usually at least 1 inch long, and we usually inject into the buttocks or the upper outer quadrant of the buttocks, which we'll talk more about with progesterone and oil.
Yeah.
So that's one of those things, a part of the recipe, right? So not only are medications going to be different, trigger dosing different, trigger medications different, you may use different methods of getting that medication to you, subcutaneous versus intramuscular. So keep that in mind. There's not a right or wrong way. It's your provider's preference. It's specific to your case, and you'll get those instructions. And then one other thing before we go into progesterone and oil, we keep talking about trigger timing, how important it is. It's timed out specifically. You have to take it at the right time. But I think one of the things that both our clients and patients experience is just sort of anxiety with timing in general when it comes to medications during the stim cycle. So we're back to our Menopur, our Gonal-f Follistim, our ganirelix cetrotide during the actual stimulation process. Laura mentioned it. You may be taking one medication in the morning, one in the evening. You could take them all at the same time in the morning, all at the same time in the evening. Clinics are different recipes. We've gone into that enough. But the timing, I think people get really caught up on the timing. So let's say you do your medications at 8 a.m. every single day. That's what you're supposed to do them all in the morning, and you take them at 8 a.m. We've had people that, I have a meeting at 8 a.m. I can't, and I have to leave at 7:30 to get to that meeting, or, whatever the case, whatever scenario is, you do have a window here. I think Laura and I both agree, and I think a lot of nurses say you have about an hour window. So an hour early, an hour late, not really a problem. Even if it's slightly outside of that, again, not really a problem. Consistency is more key than anything. And if you're getting the medication, it's more important than anything. So I think, we talk about the trigger a lot. We talk about timing. We also want to decrease people's stress out there, that when you're in stimulation, do the best you can. Try and stay consistent. If you're 30 minutes early, 45 minutes late because life happens, you are doing it correctly. We promise. Things are still happening, and no need to freak out. You didn't make a mistake or mess up your cycle.
Yeah, absolutely. I think that's a huge question I probably get with every single person that I work with is, oh my gosh, I'm going to be late on this. And I think the other thing you could do, right? I always say you can always move backwards, right? So like if your medication time is 8 a.m. and you have to be somewhere real early the next day, if you take it 2 hours early, fine. Then just don't go back to 8 a.m. the next day, right? Then maybe slowly inch it back up over the course of a day or two. Right. What I think would be more concerning is if you did it one day at 6 a.m. and then you didn't get it till 9 a.m. the next day. And even that, honestly, like in real reality, is not going to be the end of the world. You're still getting the meds, like a couple hours. I always say it's not like you hit a specific time and the meds just leave your system. It doesn't work like that. Same with like a 12-hour window. If you are doing a morning and evening, it's not like if you do them at 7 a.m., it has to be 7 p.m. It has to be that 12-hour mark. No, take it within your preferred time window. Is the goal. All right, progesterone and oil. One of my favorite topics, just because I have a ton of personal experience with this injection. And this is the one that freaks people out more than any other injection. One, because it is intramuscular. Number two, because it's an oil. And oil can cause a little bit more discomfort. Now, why do we use progesterone and oil? So I always say progesterone is typically, or it is given around the time of an embryo transfer. So if you're doing an IVF cycle and you're freezing embryos and you're doing genetic testing, right? We're not using progesterone until we get to the frozen embryo transfer cycle. Why are we using progesterone and oil when there are other things on the market like vaginal suppositories. I think there's a cream out there that they use in Europe that we have not brought over here to use yet. Time and time again, studies have shown that progesterone in oil is one of the most effective ways to get progesterone into our system. Certainly their vaginal progesterone, I think, has a real good place. And sometimes I'll see clinics use a combination of the two, or if somebody's really concerned about progesterone, maybe they're on the vaginal and they're only doing the injectable progesterone every couple of days to at least get some into your system. But it's like the key. It like is the key to unlocking implantation. Without progesterone, that lining cannot receive that embryo. Like that embryo just can't, it's not receptive to receiving that embryo. I think the biggest issue that I see patients have with this injection is the location. We think of it, right? We've said it a couple of times, injecting it into the butt. And I think people think, oh, in my like butt where I sit, right? In my butt tissue. And that's not right. And you correct me if I'm wrong. I have been searching for a right word for butt crack for like
no, sometimes you just got to like call it what it is.
So butt crack. So the way that I describe the location of this injection, there's a couple different ways to find it. But I think the easiest, if you drew an imaginary line across the top of your butt crack, and then you go up about 2 inches and off to the side, that's really where you want to be. And when I talk to people about it, I'm literally like feeling my backside at the same time. You think about it and you're like, oh my gosh, that's actually a decent, it's kind of high up. It's not hip. It's more in your hip.
Yeah.
And I think a lot of people, I see people injecting into their butt tissue and then it hurts when they're sitting and it hurts when they're bending over. And that's because like we're moving that tissue all day and sitting on it. So that's like the biggest call out. I could talk for the next 10 minutes about this. So I'm going to give you a chance here to jump in.
No, I think location is a big one, right? And I do the same thing. Draw a line in the top part of your butt crack. And then I actually say like, cut your butt cheeks in half.
Oh, that's a good way. Yeah.
Vertical line. And then that upper outer quadrant that you get is where it is. And then I'll also say another easier way is put on a pair of jeans.
Where the corner,
the upper outer corner of your back pocket hip is your injection site. Yeah. So it is more up and out than a lot of people think. And I think that's one of the biggest, again, mistakes. It's not a mistake. It's getting in the buttocks. You are, the lower you go, the more in you go, you are getting closer to nerves and things like that, which we don't need to go into. But so yes, we want you to inject in the right location, but you're probably still getting the medication. It's not a quote unquote mistake. It's just going to be more painful, harder potentially for that medication to disperse and do its thing. So we want to hit the right location. One of the things a lot of nurses do, I don't know if you guys did this at your clinic, we would draw circles.
But unfortunately, I've seen on too many times where circles are drawn.
They're in the wrong place. I know. I've seen it too. I actually just had a client not that long ago that had circles and they just kept getting discomfort and like extra bleeding and stuff like that. I was like,
send me a picture.
I'm like, weird. I don't want a picture of your buttocks, but I was like, I want to make sure you're in the right spot. And sure enough, it wasn't. And we went up and higher and to the side and much better experience. So location is definitely key for the least amount of discomfort that you can possibly get with this type of medication. You still have a little bit of an area. So just like we talked about with subcutaneous, use your surface area, move around. It's a lot smaller, right? It's not like our abdomen.
Think of like a $50 size. I don't know if some people know what $50 size is.
Now we're aging ourselves again, but yeah. So like you move around, don't try, switch sides, left, right. If you have a bruise or a knot in one side, try and avoid that if you can. I think one of my pro tips, and I'm sure you do this too, is warming up the oil before you inject it.
And don't put it in the microwave, please.
Oh my gosh.
I've seen people do this. Please do not put it in the microwave for so many reasons.
No. So warm it up in your hands, put it in your armpit.
Put it in your shirt. I used to put it in my shirt.
You can kind of sit on the vial and just, do some work for 10, 15 minutes to warm it up. It's going to make it's going to thin it out, going to make it easier to draw up. And it'll be easier to inject, as well as it won't pool. So the reason people talk about bruising and knots with this is, yeah, we're going into muscle and we are injecting an oil. So it tends to try and pool in an area.
I always say think of it like pouring oil on a pan on your stove, right?
Yeah.
When you first put it on, it kind of globs, and as soon as you turn up that heat, it starts to thin out. That is the exact like way that you should be picturing progesterone and oil too.
Yeah. So again, you could ice before this, the lidocaine stuff, the Buzzy Bee, all the things we already talked about. Keep timing as a piece of this too. You're not doing this for too long. But I think one of the biggest things is movement after, or massage after. I've seen people use like massage guns. Have your partner give you a massage. They should be helping and doing something at this point.
I like foam rollers. Or like a tennis ball, because sometimes the heel of your hand, unless your partner's doing it, but if you're trying to do it yourself, you may not be able to get deep enough to actually
do some squats, do some lunges, like not crazy. Don't be like jumping and going crazy, but just like move that muscle around. The more you can move and walk and get it to like, you've warmed it up, you've injected in the right spot, you're massaging it, you're moving it around, the less likely you're going to have that pooling, the knots, the discomfort that comes a lot with this medication.
Yeah, I always say too, so going back to those gel packs, so take one of those beaded gel packs, pop it in the microwave, and put it on the injection site right after you've injected before you do the massage, because then we're warming it up again before we move it around. Please, please do not sit on a heating pad. Please. Like I've had people do this, and in all reality, it's probably fine, but we really don't, the goal is not to warm up the entire pelvis, especially after that embryo transfer has occurred. Embryos don't like heat. It's the same reason we say don't go in a hot tub, don't put on the seat warmers in your car.
Yeah.
Like if you've done it, like please also don't panic. I have had people do it and they think they blew their transfer, and no, that's not the case. But I'm risk averse, so let's do localized heat. Again, those little gel packs are great. Just pop them in the microwave for 30 seconds, tuck it into the back of your pants right after you inject, walk around, and then after, a couple minutes, pull it out, sit on a foam roller or a tennis ball to kind of disperse. And don't overdo it. Same with the massage guns. I've seen people overdo it to the point where then they're really sore from the massage gun. From the massage gun. So, we don't have to like really work that muscle, but a little bit of massage is going to help it disperse.
And the timing piece that we talked about with stimulation meds goes here too. Now, I have had some clinics for your first progesterone and oil injection. They'll tell you to take it at a specific time, timing out progesterone exposure for the transfer. Yeah. Yes, please listen to that. Absolutely. But again, this goes along this, you don't have to, you have about an hour window. If you usually do it, let's call it the evenings, and you do it at 7 p.m., but you're stuck in traffic and you're not going to get home till 7:30 or 8.
Fine.
Totally fine. Do it when you get home. Same sort of thing. So you don't have to like be super, on top of it like you do with a trigger.
Yeah. The other thing I want to call out is if you have a partner who is willing and able to give this injection to you, I think it's ideal, right? It is very possible. I've had many people administer it to themselves. I usually say if you're going to administer it to yourself, one of the easiest way to kind of be able to turn your body is actually sitting down. You have more flexibility, I think, to turn. There are things on the market similar to like the caboodle thing. There are things like auto injectors.
Yeah.
They're expensive. If you're giving it to yourself, the benefit is that it will do the work for you when it comes to pushing in the medication. So it's like you can line it up, right, yourself, and then use the auto injector to actually administer it. It's not necessary, can be helpful. But if you have a partner who's able to help you with this, it's great. If you're like, well, I don't trust my partner, I made my husband, I gave him a grapefruit and I had him practice for a few days because it's very much the same feeling as that muscle area. So you can do that. There is a muscle in the your quad muscle. Please don't inject progesterone and oil in your quad. It will not feel good. And you can actually do some nerve damage to that area.
Yeah.
I get a lot of questions about pulling back on the needle, aspirating prior to progesterone. I always tell people, follow whatever your clinic says. It is slightly an outdated practice, but the reason for that is to ensure that you're not in a major artery and injecting progesterone into an artery.
Yeah, it's a really old school technique, and I think that can cause just some extra confusion for patients, especially if you're having to do it yourself to try and pull back on that and try and, see anything, and you're, turning and twisting and trying to do it yourself. It is very outdated. Agree, follow your clinic's instructions, but it is a very outdated thing that many clinics are getting away from, and it's not part of the instructions anymore. I don't love auto injectors personally.
I don't have any experience with them.
I mean, there's some people that love them. Do you completely? They inject awfully fast.
Oh, really?
I don't know if you have seen it, but it's like a dart, like boom, like so. I get it for the convenience. I get it. And some people love them because it helps and support. Again, try it. It doesn't hurt. They can be expensive, and then you're kind of wasting money there. But whatever you think is going to give you most comfort. I don't love them quite so much. I think one of the pro tips in general, just injecting in general, that I don't think a lot of people talk about is always inject with your dominant hand.
Yes.
And it seems self-intuitive, but you hold the area, whether you're pinching or stretching, depending on the injection, and then with your non-dominant hand, and then inject with your dominant hand. So that goes the same for if you're twisting and kind of going on either side. Always maintain kind of that dominant hand injecting and your non-dominant hand holding or pinching. And I think a lot of people should have a needle.
I know. I was thinking about that. I'm like, I have a whole box upstairs.
I know. I think a lot of people see like, oh, well, we inject kind of like this when, you're pushing almost like, you have your two hands on the syringe part and you're pushing with your thumb. Mm-hmm. That can be hard to do when you're trying to inject in these different places. So don't think that's the only way you have to do it. Like you can press the plunger down with your pointer finger. Mm-hmm. You can hold the syringe completely in the entire palm of your hand. Yeah. It's honestly one of the easiest ways, and just push down with your thumb like you're playing thumb war with somebody. That's the easiest way too. So I think there's a lot of tips and tricks that we don't talk about to potentially avoid needing to purchase something like an auto injector. Yeah. Because I think people think they have to inject a certain way because that's what we see on TV or that's what we see in our video. But there's ways to get creative with it to make it work for you.
Yeah, I think Ashlee and I have a lot of tips and tricks that we probably haven't even discussed on this call. So if you have questions and you want us to answer them, I mean, I could talk about this topic for a while. Yeah. It's just been such an easy conversation, and I think we've only scratched the surface. Yeah. Because again, those recipes are different for everybody, and there's so many different combinations of drugs that physicians are using and adding into protocols these days. So if you do have questions, please hit us up. We've been talking for quite a long time, so I think we'll cap it here. But please, DM us, like, comment, subscribe. We want to hear from you, and we will see you next week.
See you next week.
If this conversation resonated, like, comment, or subscribe, share, send us your questions. Nothing is off limits.
And wherever you are in your journey, know this: you deserve support that's real and human. Never forget to ask your questions, advocate louder, and remember, you're not crazy. Fertility is hard.
That's it for today's episode of Fertility Nurses Unfiltered. Thanks for spending your time with us today.
We'll see you next time.